Right. Well, thank you very much for the invitation. I think that it's wonderful to have this, to use the Zoom for purposes of getting together and talking, and possibly also continuing the contacts which are established by Zoom in later work and in collaboration. So I will speak about the ways in which we have to think about reorganizing our care and psychiatric services, because the world as a whole has changed in ways that we never expected it will. Here are some of the main socioeconomic changes and trends which we see in the year 2024. They are listed here, and I shall say a few words about each one of them. From urbanization, the curious word commoditification, and others, I think that each one of these trends is a powerful impact on all that we are doing in the field of mental health. So urbanization, as you know, is at present unbelievably fast. We are countries now, like, for example, Argentina, in which 95% of the population lives in towns. But what is more, it's not only that 95% lives in towns, but most of the people have moved to towns in the last 25 years, which means that there are large numbers of people who come to town, they don't know each other, they are living, trying to find a living on the ever more crowding surfaces of towns, with a rapid creation of slums and a almost complete vanishing of the communities which previously existed, which really, to a large extent, makes us think whether the principles of community care, which have been the principles which we tried to promote in the middle of the last century, whether they are at all possible. We see all sorts of symptoms of the problems which the disappearance of communities does support. For example, the increase of crime, the increase of drug use, the dependence on certain centralized services, but also with a very rapid growth of problems which we never had before, such as the problem of aloneness and loneliness. Aloneness being the fact that a person is left alone and has no contact with anybody who could look after him. And loneliness is really a feeling that people are not alone, that people are not connected. You take a town like London, 30% of all households are single-person households now, or you go to other countries and you find that it's even higher, the proportion. So bad it is that, for example, a country like Japan has now created a Ministry of Loneliness, which is a ministerial sector that is trying to find solutions both for loneliness, which is a sensitive feeling, and for aloneness, which is in fact that people are left alone without any contact or with any help from anybody. How bad it is? Well, it's bad. It's so bad that people are now starting legislating. In China, there was a recent law which punishes children who have left their parents with whom they live in the same town and they don't look after them anymore. And even a country like Bangladesh, similar law of forcing children to look after their parents has also been passed. But we are seeing that this is the loneliness and aloneness are big problems that have become more recent. And then we see also in many countries, particularly in the low-income countries, they have become now parts of the town which are living where people who are more have more money live, and it's very beautiful. But they have surrounded themselves with a wall very often, and in some towns like in Manila, for example, this is a barbed wire which protects the settlement of very well-off people from everybody else, people with machine guns standing there and making sure that this particular group is not open to everybody who would like to come. And I think that these fortresses of the richer people also bring another sense to the meaning of living together in the same setting. So urbanization is one of these problems. The next one is what has been called commoditification. It comes from a word commodity. It was first used by an officer of the World Bank. And it basically says that the time has come in which everything must be used as if it was a commodity, like sugar or iron or cotton. So that healthcare is also a commodity. You get as much as you pay for, and everything else becomes a commodity. Care for other people is a commodity. And of course, that means that the relationship in the way in which we are dealing with people and services have completely changed. All social relationships now have also been turned. How much do we make in terms of money if people talk to one another? Is the question that people will ask now. And I think that that notion that everything is can be bought or sold changes the way in which we are seeing health care, help to other people, and living together. And what is also worse, that unless you put a price tag on a particular thing, it just vanishes from the government programs and from everywhere else. And healthcare is also a commodity. How much do we get in order to, how much would it cost to achieve such and such a financial result, which becomes more important than whether people are feeling better, whether they are less plagued by their disease, or whether they are able to live and love their family. The commoditification is a dangerous trend, which unfortunately is present everywhere. The next trend is the one on fragmentation of labor and medicine. Fragmentation was first a term that has been used in France to describe the feeling which people had in factories, which had a running chains. That is, everybody was doing a particular task to contribute to the final production of a car, but nobody saw the car anymore as a whole. They were each doing a little piece. The labor as such has been fragmented. It's not like a person who produces shoes. He works for a while, and then he produces it, and in the end, he has a shoe to look at. Fragmentation of labor has led to the point that nobody has a feeling that he's produced anything. And that, of course, is a very significant contributor to the burnout feeling which people are describing. A recent survey of young psychiatrists in European countries has shown that about 50% of them have, in one form or another, signs of burnout. And when you ask them why, many of them say, well, we are just feeling that we are continue to contribute under very often very strenuous conditions, but we see no result as we would like to see it, because there is no personal responsibility and there is very little that can be done this way. Fragmentation of medicine is also going in another sense with a huge development of specialities and subspeciality. Now, it's understandable that there should be specialities because the knowledge has grown so much. And it's also understandable because high-skilled specialists are paid much better than those who are working in general care. But the point being, however, that as medicine is fragmented into pieces, not only are doctors at a higher risk of burning out, but at the same time also the care becomes incomparably more complicated and incomparably more complex. People have thought that maybe working with telemental health will help. Perhaps it does to an extent, but not completely. And the split into these various disciplines means that no doctor looks at the human being as a whole. They all look at their specific organ and specific speciality which they have. And if you have a more than one illness, which most people in advanced age will have, it's very complicated to organize it because there are different doctors who are looking after different conditions. And the Americans have found a solution of employing yet another person who is called a care manager and who will take people from one doctor to another and from one service to another to help them to survive in this way if they have more than one illness. And of course, this is becoming very important because comorbidity is on a sharp increase. We have saved people from dying and they live a much extended life expectancy. But the new years which they have got are not healthy years. They are years which are very often full of disease and problems and suffering. So this was the third of these trends. Then we have the demographic change, which is important as well. We see that the number of elderly people are increasing. They have a huge amount of divorce in many countries of the world. And this change of partners does not only liberate the partners, it also leaves very profound traces in the upbringing of children. For some of them have maybe 2 or 3 mothers, if you wish, in the course of their growing up. And there is no stability in the family structure which would inspire young people who grow in their situation to do something similar and to build a family of their own. And I think that the capacity of the family to withstand problems is significantly reduced by this sort of loose relations which exist in many places. We have also another change, demographic change, that so many people work out of their homes, which means that they cannot look at those members who are sick or disabled. And not only, in other words, is it impacting on the care and the cost of care, but also on the upbringing of children. And I think that these changes, both the instability of marriage and the increased rates of employment out of home for both parents, has significant impact on mental health of themselves and of those for whom they are supposed to look. And then there is another phenomenon which is perhaps less well known, which has now been described in various countries, which is being described as horizontalization, which basically means that people are horizontally connected. Adolescents speak to other adolescents, and they have a language and a talk which is more or less the same among adolescents, but it's not understood by their parents, nor is it understood by younger children. And equally so, within professions and within layers, the elderly people speak a language which only they understand. And the fact that this happens is not only breaking up the community, but it also means that knowledge which has previously been transmitted vertically from father, from grandfather, children, etc., is not being transmitted anymore. So that we are having a big problem of having to educate or bring knowledge which previously was transmitted very fluently within the chronological ladder. And of these, I think the development also contributes to make the older people quite lonely, because since the communication is horizontal, they get more and more lonely because their friends and relatives, etc., of their age, they die away. And so they stay very lonely without connection vertically to their families or to younger people in their place. Digitalization, people have been speaking about it with enthusiasm, thinking of how much it can improve medicine, increase the capacity to diagnose and to give us good answers. Unfortunately, also contributing to the dehumanization of medicine. Sorry? Sorry?
Okay.
Should I stop talking?
No, just go ahead. I think sometime...
Please continue.
Please continue.
Okay. So I think that what has been called the social capital, which is the sum total of good things that one person does to another, a smile or a good morning or various other things which have sort of made us feel better and which have gradually, with services to one another, increased the social capital of societies, is now taking a downward trend. And then we should remember also that digitalization is not only knowledge, it is also the capacity to learn, so that elderly people have a little bit more difficulty to learn how to use the digital possibilities. And furthermore, it is also important to buy or pay for machines that will make digital communication better, and that is not necessarily available in many places, particularly in the area of healthcare. Now, here is a list which I think you would recognize. It's something that we have seen in any document in the 1980s. This is the kind of thing that we were worried about. Placement of people with chronic mental illness in the community, finding ways of dealing with common mental disorders in general health care, teaching general practitioners and so forth, how to close mental hospitals in first in industrialized countries and later in other countries as well, how to help people who are drinking too much, and how to find some support to children with defects or delays of intellectual development. This was sort of a normal menu, a normal set of problems that we expected. Anybody would ask you this in the 1980s, you would bring these kind of things. But look at 2024. Practically all of them have been surpassed in importance by other problems. And I'm listing some of those. The loneliness I mentioned already, the breakdown of carers. Carers of people who have mental illness have as much as 2 to 3 times more physical morbidity than the normal population, which does not have any care to anybody. Violence in schools and bullying in schools, crimes, adult crimes where children shoot their parents or other people or do terrible things to one another and to others. A significant epidemic of drug problems, which are very different from the drug problems which we have seen in the 1980s, where now it's becoming very widespread. Not only that, but also the drugs which are being used are lethal. They kill. They not only cause their drug dependence. The burnout is described as the new epidemic at work. Family ties, I already mentioned, are falling apart. We are now suddenly become aware of the many human rights violations in various types of service. And while we would like to remove them, we know that we need also more resources, not only the goodwill to remove them. And that makes people unhappy about their work because they know they're doing things which are not as they should be done. And of course, the gender-related problems, in particularly in European countries, but gradually elsewhere as well, in which people would like to change their sex. They would like to do this before the age of 18, and parents take the responsibility. It was unknown in the earlier times. And now, of course, some of the problems of the 1980s are still with us, but these kind of new problems are now preoccupying us much more. So all of this brings us to some new priorities for mental health systems. We must first admit that the past decades have made advances in many things. We have, in the 1980s, the use of medications has become very possible. When I started working, there were a few medications, but as we went into the 80s and the 90s, the number of medications became very large, and many people have got considerable help from these new medications. We have learned and we have been able to train many general practitioners and other health assistants and so forth in basically in treating common mental disorders in general practice. And I think that was very important. Some community care has also been developed in countries, not everywhere, not equally well, but we have community care and good examples in many places. But the new problems which now emerge under the impact of the trends which I just described require that we shift our priorities to a certain degree. And here are what I think are 5 or 6 things which I think we should think about. The first one is to consider to what an extent psychiatrists and other people in the field of mental health can become social activists, arguing that it is necessary to engage and bring other people to do the work for us. I'll give you an example or two in a moment. The second big area in which we have to add new force is the support to what has been called the forgotten population groups. And I'll speak about that as well. There are new places where we have to do our work. There are changes which are necessary in the way in which we are trying to train people for mental health care. And finally, there is a need to revise laws and rules and provide every single one of them with a sunset clause saying this law will be valid for 3 years. And we have to relook at it again because maybe in 3 years, the world will change so much that we have to think of other ways of legislating. We are now living with numerous, very obsolete laws, which are more of a disturbance than a. So here's a few examples of what we could do when I speak about activism. One of the things that is necessary is to involve other systems, education, security, etc., For example, when we are working with social isolation and loneliness, we as psychiatry are chronically known as being separate from these other sectors, but we have to sort of walk towards this. We should think about in promoting in our contact with other people primary prevention. I'm just to give you one example, which is the example of iodine deficiency in pregnancy. We know that iodine deficiency will lead or highly increase the probability of cretinism in the child. Every year, there are about 4 to 5 million cretins which are born because their mothers have not been given iodine and not been told to take iodine or not been given iodine. It's one area in which the psychiatrist cannot go around distributing iodine, but in which his relation to the ministry and to other authorities, to general health care, must become such that say, like, we have these 6 or 7 diseases in the field of mental health, which can be reached by primary and by secondary prevention. Please do the following. Equally so, I think that we have to think about the inclusion of work against stigma as being a normal part, routine activity of our healthcare system, which we are not doing at present, and therefore may not happening. A second group of priorities, in my opinion, is dealing with some of the neglected groups in society. Take, for example, the children of people who have been imprisoned. Who in our field has been giving any thought to helping them, to doing something about these children, or for children who have mentally ill parents, or for children who are maybe having parents who are suffering from some other difficult disease?
Yeah.
I think the notion that we have to think about, we can include the action to help carers. Why? Because they're breaking down. That's why. And they are dropping their people for whom they have to care because they can't do it. It's too much. And there are ways.
Let's continue. Please, Norman, continue.
It seems to be a network issue.
From which side is that then?
The screen is freezed, so it will start again. It will start again once the network becomes, yeah. Probably we lost connection with Dr. Norman Sartorius because of the network issue. Hello, right?
Yeah.
How
All
long?
right.
Yeah, bring it up as much as you can.
You lost the slides.
Yeah.
Yeah,
So I'll be back.
yeah, just okay.
Hello. Yeah. So just continue, Norman, please.
Can you see the slides?
No, we
No, it's
can't
not.
at the moment.
Yeah, well, maybe we should see the slides because, well,
Yeah, it's fine. If you just don't worry, take your time and
all
just
right, so I will continue. Never mind.
share
this.
again. Please share your slides again. It's no
Right.
problem. And all the others, please unmute your phone.
Right. So I mentioned the
Normal,
one
please share
of
your
the
slides. It's no problem.
yeah.
To do it again, you have been kicked out.
So I should just continue talking without slides.
No, you can start the slides again. That's no problem.
Okay, let's try that.
You can make Professor Norman Sartorius his co-host so that he can start sharing. Yeah, yeah.
Mhm. Okay. We can see your slides now. The slides are
You
back.
can see them?
Yeah.
All right. So, so I said that if we want to help carers, not only should we give them some money, because wherever this has been done, it's been done with very good effect. After all, by liberating a bed in a hospital, there is some saving, and that saving should, in fact, in part, follow the patients, not stay in a hospital as it is. It's not always easy to achieve this, but when it is done, it's miraculously effective. We should express some respect for the work which the carers are doing. In some countries, for example, in the United Kingdom, there is an annual recognition of the best family that has been looking after people with mental illness. But there may be other ways in which we can recognize the work which they are doing. We should also invite them to come and teach medical students about the way of looking after people at home, because they know it, we don't. And I think it's very important to do this. And we should also try to listen to them when they talk to us about the way in which things could be done. And we should learn that carers are sometimes overburdened, and that if you have an overburdened carer who maybe looks after a demented father with very little money, with other problems in the family, if we load another mental patients into the family, the whole thing will break apart. But at present, in no country of the world is there a questionnaire that would say, let me assess the carer before I discharge the patient. I must see whether the carer has in fact too much on his shoulders before I can discharge yet another burden upon him. And then I think another example of what we could be or should be doing is to involve migrants and refugees in services which will see migrants and refugees. They're very rarely employed, although they have the great advantage of speaking the language fluently, and very often it would be an employment which would drain them a little bit of their self-respect, maybe also give them some money, but we are simply not using them, neither as consultant nor to employ them. I've seen a number of them who are happy to work for free if you just invite them to come. Then I think that there is a third priority. I think that we should argue also for an additional emphasis on child development, argue for legislation about ensuring that children which are born have have parents who have the time for them. In some countries, it has become now possible to extend part-time work of one or both parents over a longer period, which has been very useful. In some countries, the total time in school has been reduced, for example, in Finland, to 4 days per week, so that the parents can spend a little bit more time with their children, and children could speak time with other children as well. There are various other ways in which we have to think about the upbringing of children. We will say this is not our business. It is our business, because many of the problems will be resolved if we are able to help these children not to suffer too much and become candidates for various kinds of mental breakdowns. We should also, in the same time, think about training teachers a little more about mental health matters. I've recently done a survey in 16 countries, and I found that only 2 out of 16 have regular training in matters about mental health in their normal education. It's worth at least proposing it. And then, of course, the recent programs of safe spaces for adolescents have been extremely helpful and have been done in some countries with great effect, for example, in Australia. But I think maybe the safe spaces are not as luxurious and the Australian ones, but the ones that I've seen in operation in Kenya have been much simpler and simply allowed adolescents to come to speak maybe to another person who is a little bit more knowledgeable, a nurse or somebody, and to other people in a safe environment in which they can spend time. Many words have already been said about collaborative care. This might be an area where various kinds of digital help and could help to get a bit further in providing care to the epidemic of people with comorbidity, with more than one illness. But this, unfortunately, at present is not done as much as it should be done. I also think about, as I spoke earlier, about the burnout measures. Many of the burnout could be prevented by relatively cheap, and some of the measures that could be taken are even free. But it would need that a psychiatrist start thinking, can I do something there? And finds a little bit out of his daily time to help others to do something in this area. An area of care which I think requires direct influence of psychiatrists is perinatal care, not only because we can educate much better during the perinatal period than any other period in time, but also because there is a variety of problems that can be resolved if appropriate guidance is given to parents. I'm telling very often an example of a niece of mine who has adopted a child, and she expressed the wish to adopt a child. They said, all right, yes, you can adopt it, but you have to go to a course. So she went for the course. 6 months later, they learned them, and they adopted the child. And my question then was, how many of the mothers normally have 6 months training in order to be ready for the child when it comes? And perinatal care can, in addition to looking at the physical, look also after the mental health of both the mother and the father and the child, if we give them appropriate guidance. Now, I think that to do all this, we need to consider changing the training for mental health care professionals. The one that I think is of crucial importance is to introduce very significant amount of communication skills training as an obligatory part of training of health professionals. I see doctors today who do not know how to speak properly. Nobody has told them how to listen. And some of them have learned it, have the gift, but many of them are listened so poorly that their service and the time which they spend with the patient is not really helpful. And I think listening, talking, explaining, many of these things are in fact things that can be learned very well. These are skills which can be acquired if we give time for them to be done. We should also think about training doctors, nurses, lawyers, social workers for at least a part of their time together. Because not only will they have they got the same things to learn, but in addition, by being trained together, they may respect one another later on when they get into jobs and when they work next to each other. And then there is one thing that has been recently been mentioned as well, and that is what has been called the escape route. Many people in the work, which particularly in our field, in field of mental health and psychiatry, etc., and after a certain while, they discover that it's not for them, that what they're doing, they neither gives them pleasure, nor they're doing it very well. But they stay because there is no place to go. And the notion that should be a part of thinking about the service system to create what one say other types of jobs which can be used as an escape route for people who are deeply dissatisfied is something that is very important to consider. Finally, I think that the legislation which we are having must be reviewed, and every single law that we now produce must have a sunset clause. We should not have any more laws which have no sunset clause. A sunset clause means that you pass a law or you put forward a law which says this is a law about mental health services and we will review it in 5 years' time. Because the world may change so much that what we now have will not be valid in 5 years' time. So we have to change the law again. But to bring something on the agenda of the parliament is very difficult. And so foreseeing that you will have to review it, a sunset clause is very important. Otherwise, you get a situation such as in West Africa, where laws are copied from the French law on mental health, which was passed in 1898. And I think the notion that you have laws which are completely inappropriate for the situation is just making our services and our work a waste. We should also find ways of not doing all of these services and things alone, but listen a little bit more to people who have had mental illness, people who look after people with mental illness, and listen to other professions in thinking how best we can organize our work. The fact that psychiatrists had most training of them all, many years, etc., doesn't necessarily mean that they have learned everything that they should about organizing a service properly. And I think that collaboration within the team is of great importance. So, dear listeners, the recent changes of societies and the ways of life which have changed require that we re-examine our priorities and ways of working in mental health care systems. And this will not change because of governmental pressure. It will change if and when we are our priorities. We must examine what our work is at present and decide and then do something that would improve it, make it more appropriate to today's situation, make it more appropriate to the needs, not only of the patients and their families, but also the needs of professionals who work in this field. I thank you very much for your attention.
Okay, thanks very much, Norman. I'd like to open the discussion, and there's many younger people who possibly might be have questions, and I invite that. And to make it much more easier, I think Norman, I see where you're coming from, and I see the needs. I'm working myself for quite a while in psychiatry. I would simply say, is a society ready for that? Are they ready to listen to that? Where are the people who can convince other people to do that? So is it okay?
I think that, an epidemic doesn't strike everybody at the same time. Yet at the end, all are sick. And the same is true with this. The fact that the whole society doesn't change doesn't matter. What is important that people start changing in a small scale, infecting others by their way of work, by the successes which they have, etc. And I think that the movement can start by multiple examples of people who have changed their way of work, which then gradually becomes a habit and everybody does it. We have seen that many of the rules which immediately cover everybody are not really very effective. People avoid them, run away from them. So I'm much more for gradual development of people who take new conscience and try to change the way in which they see things and then infect others by their enthusiasm and by the new ideas which they are putting forward.
I think it's a
So
good
I'm not
idea.
hopeless. I think that gradual change is something that I would see as a model that we should seek.
The thing is, my experience is that we are, as psychiatrists, more and more isolated very much into giving medication. And I must say, sometimes I don't feel listened to. And I'm just, working in Britain now and, having just to prescribe medication and being the expert for clozapine and, even, so I think the roles, I think I think possibly we as psychiatrists have to not accept the roles corners that we are cornered into a very small slice, and I think this is I think we possibly, and this could be that we have more multidisciplinary teams, and I think this is more and more important than ever.
Yeah, I think that it's perfectly true, and I think that in a way, it reminds me of very often when I think about mental health services, of the story that is told about somebody who goes along a road and sees a man who sits there crying bitterly, and he asks him, "But what happened to you? Why are you crying?" And he says, "I'm sitting on a nail." I say, "But why don't you get up?" He says, "It's easier to cry." And I think we find ourselves very often in this situation. It's easier to complain than to change. And my hope is that since we cannot expect that everybody will change at the same time, that there will be people who will change and others will be affected by their example. Because I think that that is a much more likely way that things will happen, rather than expecting that the governments will suddenly spring and revise everything that we are doing.
Okay, is it Dr. Joy? Are you having a question? I think.
Yeah. I'm Dr. Joy. I'm from the UK. With the due respect to what Dr. Norman has explained to us, I would also like to add something with respect to the security point of view. In ancient time, there was efficiency and effectiveness, one of the vital points, especially among the managers and people development. Nowadays, the most pertinent aspect we have to deal with is insecurity feeling on account of the mounting fraudsters and the cheating technology, what I call, of the 21st century. There is no efficiency we can see, but wherever we go, there we can see only the hidden agenda and cheating technology, especially in the field of finance. So we have to include those aspects also into the changing scenario.
Norman, do you want to comment on that?
No, I think it's a very important point that has been raised, but it's a point. It's in addition to what I said, not don't need to continue on that.
Okay, that's fair enough, Is there any other questions? If you have a question, you have to unmute yourself and you will come up straight away.
Professor Norman, Dr. Sujit here. My question is, the mental health priorities are continuously changing and the priorities are different in different countries. But the policymakers, when they make a policy, it lasts for quite a long time. And the policy amendment or policy changes happen after a long time. By that time, a lot of changes happen so far as the mental health needs are concerned. So how to make a balance between the changing mental health priorities and the policies that are made by the governments?
Well, there are two ways of thinking about change. The one way to think is here will be a Minister of Health, which is very bright, well-informed. He has been named minister, and he now says he calls for people to advise him, and they get advice, and they do a change. And sometimes that happens. It's a reform of services. And it's wonderful when you get a minister like that. But very often the ministers are not like that. They're preoccupied by their own career. They are full of prejudice of yesterday. They don't know anything. They don't want to listen to anybody. So it's very difficult to overcome their, I think, block by doing nothing. And that's why the answer which I gave a bit earlier, that's why I think that it's very important to start small and start on an individual level. Maybe, I do not know who the people are here who are currently attending, but if any one of them is a teacher of medical students, he might wish to change the students that he is teaching, not waiting to change their curriculum of medical schools. And my sense is that we must stop expecting that there will be a saving law which everything will change, and rather think of a gradual development of many of these ideas. Some things will require political action because, for example, there might be changes in the acceptance of the United Nations Convention on Rights of People with Disabilities. That has to be done from top to bottom. But for many other things, it is very important that people try things which they think are useful. If they work, they can infect others by their enthusiasm. And then today there is one who does this, tomorrow there are two, and gradually things change. The greatest philosopher of our times has been Mr. Kuhn, who in fact said that we are having a current paradigm of certain rules, regulations, relationships, etc. And to change the current paradigm, you cannot break it straight away, but it's being eroded by small changes that happen in many places. Eventually, the bad system, which we don't like, breaks down, and the new one emerges combined and composed of the contributions of individuals.
Yeah, can I ask you, so I still think, is a society, sometimes I think things change so quickly, like artificial intelligence. Can you really expect that people can follow this, or that the whole of the process of, let's say, a minister understanding things, needing the change and all this, what happens, to some extent, what you say, what changes is sometimes very, very fast, so fast, that we have children who have no guidelines anymore. We have children of people who have where the parents are crack addicts, and this, we have people where the parents die from fentanyl addiction. So I'm thinking about drugs. Things are coming very, very quickly, and is society, how can you speed up and then you get artificial intelligence? People are now going, people have money to go to the moon or fly around the earth, or maybe and that's the next holiday. So,
I'll give you an example that I think replies partially to what you have said. There is a huge number of new things that happen. And for some of them, they could help us, but we are not using them very well. I remember many years ago, I went to Pakistan. And in Pakistan, I had to advise the ministerial office. So I was told that I would see the minister. I waited for quite a while to be in his office there. Finally, he saw me. He was thinking about 1,000 other things while I was talking to him, and I left very disappointed. But the colleague who was introducing me, who was in fact looking after me, he invited me to go and speak on television. And I spoke on television. I said the same thing on television as I did when I saw the minister. But suddenly there was a reaction because he listened to the television in the evening. He didn't listen to me in the office. So maybe we should think a little bit of coming into time in which we are and using some of these extraordinary tools and new developments that we have, because they might help us to get progress where previously this was not possible.
Okay. Any other questions? I think there's none. I think, Norm, I'm really, really grateful for your support. I'm really grateful for your ideas, and I think I learned so much, and I have to change myself to be a better teacher now. So that's a bit of a tricky one. But anyway, I try my best, and maybe part of this, whatever Global Psychiatric Association stuff, is that we are more flexible in getting these ideas out. So yes, so thanks a lot, Norman, and thanks you so much. And do you want a final word? If not, I will possibly dash on and go to Danuta Wasserman's talk.
Thank you very much for inviting me. And I think you're doing a wonderful work for people who made together like that and think about the future, which is very important. Thank you very much for inviting me.
Okay, thanks so much. Okay.